the other 60%, polygenic background, add on obesity and or hypertension, and that leads to the phenotype of HCM. So generally, older, the patients are diagnosed older, maybe without a family history, more commonly isolated basal septal subtype. You can see that this is environment plus genetics. So again, an old slide that suggests that 2/3 of the patients have LVOT obstruction, 41% with a resting gradient more than 30, and another 27% or so with a provocable gradient, either with Valsalva or exercise, and then assorted other morphologies. But with increasing recognition of the disease, better echo, increasing diagnosis, better education, I surmise that it's actually more like 50-50, that more patients now are being identified with non-obstructive HCM because 20, 30 years ago, we only identified patients with symptoms, the patients with a loud murmur, who then went on to echo and had obstruction. But now we're identifying many more asymptomatic, non-obstructive patients. And so I suspect it's closer to 50-50 now. So these are typical echo images from different patients with HCM on the left, and diastole in a patient with massive septal hypertrophy, and systole on the bottom. You see that there's systolic anterior motion of the mitral valve. That's due for a couple of reasons. One is that in HCM, the mitral valve is generally elongated. Secondly, there's increased velocity of flow along the thickened septum that, due to venturi forces, pull the anterior leaflet of the mitral valve towards the septum. So multifactorial. The top right is a patient with apical HCM, which can be tricky to make the diagnosis accurately with echo. Contrast is important to improve the ability to identify apical HCM by echo. So as I mentioned, the etiology of SAM, here you see in the apical 5 chamber, a nice example of SAM, and on an M mode during systole, again, systolic anterior motion as the septum abuts the anterior leaflet of the mitral valve. Classically, by echo in patients with obstruction, you often get this V sign where you have concomitant turbulence in the LV outflow tract due to the SAM. And as the anterior leaflet of the mitral valve is pulled anteriorly, you get the posteriorly directed jet of mitral regurgitation. So quite often in patients with obstruction, you see simultaneously MR. Importantly, with Doppler is to measure the outflow tract obstruction, typically with continuous wave Doppler and the apical windows, looking for the classic late peaking dagger-shaped shape of the envelope. We've talked about obstruction, MR, and intracavitary obstruction can be identified as well. This is the classic appearance of the late peaking dagger shape envelope using continuous wave in the LV outflow tract. Again, important to differentiate that from mitral regurgitation, which tends to be holosystolic and round in shape, because many patients with HCM have, again, concomitant MR along with their LVOT obstruction. So turning now to the use of CMR in HCM, this is a patient from UVA. It was an interesting subtype with reverse septal curvature and apical HCM together. CMR is the gold standard for measuring LV mass, LV volumes, assessing the morphology of the HCM. We certainly can measure the LVOT gradient and assess MR, but that's done well by echo. So that's not necessarily the reason one needs to do CMR and HCM, but we'll talk more about why in a moment. These are 6 different morphologies that we described in our HCMR baseline paper, which was published in JACC back in 2019. About 40% or so excuse me, 45% or so had this were patient like patient A, isolated basal septal hypertrophy. Another 40% had were like patient B with reverse septal curvature morphology with the thickest portion in the mid septum as opposed to the basal septum. About 8%, again, this was out of 2,750 patients with HCM in HCMR, and we'll talk more about HCMR in the second half of the talk. About 8% had apical HCM, 1% had concentric morphology, like patient D, 3% had mid-cavity obstruction with apical aneurysm. That's a known high-risk subtype with which in the U.S. guidelines is an indication for an ICD because of their, excuse me, increased incidence of VT and leading to VF. Patient F is actually a patient of mine who fits in the 1% who didn't fit in any of the other 5 categories. She has isolated lateral wall hypertrophy. So we know that measuring LV mass is important, and that was based on this older paper from Jacopo Alivoto and colleagues in Florence, showing that patients with markedly increased LV mass have reduced survival free of HCM-related death compared to those with normal or mildly increased LV mass. So keep this paper in mind when we come to the HCMR outcomes paper that I'll discuss at the end. This paper dates me as one of the first papers I published. You know, if I was a teenager at the time, of course, but this is in a small group of patients with HCM, in which we applied, you know, well before echo strain was available. We applied tagged CMR. And this is a patient with apical HCM, and you can see the normal myocardial tag deformation at the base of the LV. These square boxes become trapezoids at end systole, but you see the markedly abnormal deformation in the hypertrophied apex, which is multifactorial due to the hypertrophy, the myofibrillar disarray, scar, etc. You can actually see expansion of these boxes, so there's the strain may actually be positive in these in the apex. Here is a patient with a different patient at end systole with marked septal hypertrophy. You see the normal deformation of the subendocardium in the anterolateral wall, but abnormal deformation throughout the septum. And we showed in this relatively small cohort back in the early 90s that percent circumferential shortening in red in the HCM patients was reduced throughout the LV, save the lateral wall in this cohort who had primarily asymmetric septal hypertrophy. But most importantly in HCM is the identification of late gadolinium enhancement or replacement fibrosis. These are 6 different patients with HCM. In HCMR, 2,750 patients, we found LG in exactly 50% of the population. And that HCMR represents a low to intermediate risk patient cohort. You could find higher risk cohorts with a higher prevalence of LGE, but in HCMR it was 50%. In most studies, the range is 50 to 60%. Patient A has no LGE. Patient B has confluent LGE in the anterior wall, but there's subendocardial sparing. So this is not an infarction. In infarction, the wavefront necrosis starts in the subendocardium and progresses to the subepicardium, and there's also midwall fibrosis here in the thickened infraseptum. Patient C has the classic form of scar in HCM, which is RV insertion site fibrosis. Patient F has severe asymmetric anoseptal hypertrophy as well as fluffy diffuse LGE there. So the presence of LGE can't be an indication for an ICD because the risk of sudden cardiac death is now in 2026 0.4% per year. So you certainly can't put an ICD in half the patients because you'd be putting in way too many ICDs. So That being said, this meta-analysis from a decade ago in JACC imaging over 3,000 patients, the presence of LGE is a marker of adverse outcome in terms of all-cause mortality, a 1.8-fold increase, cardiac death, nearly 3-fold increase, sudden cardiac death, 3.4-fold increase, heart failure death, 2.2-fold increase. But most importantly, so shown in these two papers, the extent of LGE is an important marker of sudden death. The paper from Chan and colleagues, led by Marty Marin, was a study of 4 quaternary sites that take care of some of the sickest HCM patients you'll find, because their baseline sudden cardiac death rate was 1%, so very high risk group. And what they showed is that once your LGE was more than 15%, your per year sudden cardiac death risk doubled to about 2% per year. So it was this study that put this number of 15% on the map. You can see the stepwise increase in number of sudden cardiac death events from 0 LGE all the way up to more than 20% LGE. The study on the right is from the Cleveland Clinic group led by Melinda Desai, who was part of the HCMR executive committee. And you can see that in green are whether you're obstructive or non-obstructive, patients with LGE more than 15% had increased events, less freedom from primary composite events. Now, is 15% the right cutoff? It is a continuous variable. This was a study published in the European Heart Journal that I had the pleasure to review back before it was published in 2023. 774 patients followed for over 7 years. In maroon are the patients with sudden cardiac death events. You can see that the majority of the events occurred in those with LG more than 15% of LV mass. That being said, there's still a substantial number of events in the patients with between 5 and 15% LGE as a percentage of LV mass. In fact, this meta-analysis from 2 years ago in JACC imaging suggested that the optimal sensitivity and specificity for predicting sudden cardiac death may be 10% using the 6 standard deviation technique to assess the amount of LGE. I'll speak for a second about quantitation. In HCMR, we used a visual analysis. Your eye does very well at picking out bright replacement fibrosis and differentiating that from gray, lacy interstitial fibrosis. But the visual approach agrees very well, as published, with the 6 standard deviation technique, measuring any signal that's more than 6 standard deviations above of the noise in a normal segment. So these are the 2024 ACC/AHA guidelines for ICD placement. And you can see that CMR identified several of the findings. One is massive LVH, wall thickness more than 30, apical aneurysm. We talked already about why that's high risk. End stage, so-called end stage HCM, which is an EF less than 50%. Then some historical features, family history of sudden cardiac death, unexplained syncope, which can be a difficult issue. And then some non-sustained VT is also a 2A indication on monitoring really prolonged episodes of fast VT. And lastly, extensive LGE on CMR, and that was considered a 2B indication, so less strong indication, maybe a tiebreaker in the 2024 guidelines. We'll come back to that. So CMR is also used in clinical trials in HCM. I was involved in the CMR sub-study of the Explorer trial, small N, only 17 patients in the mavacamten and 18 in the placebo group, but the power of CMR is the ability to make observations in small n because of the fidelity of the data. So what we showed in this letter in circulation back in 2021, led by Sarah Saberi from University of Michigan, was that the CMI, in this case mavacamten, was associated with reverse LV remodeling over the short time period of this study. It was around 26 weeks, as I recall, that mavacamten was associated with reduction in LV mass index, reduction of 2 millimeters on average in the maximal LV wall thickness, a reduction in left atrial volume index, and no change in the amount of scar, which you wouldn't expect. Or you would expect no change, so they put it that way. LVEF, as is a known side effect of the CMIs, fell by 5% in the treated group. And here are representative images, but here are more easy to see images taken from our paper in JACC in 2024 from the Sequoia study of aficamten in obstructive HCM. You can see in the treated patient here with reverse septal curvature, actually basal septal hypertrophy HCM, their maximal wall thickness fell from 21 millimeters to 18 millimeters over the, again, short several month period of therapy with aficamten, as opposed to no change here seen here in this placebo patient. And again, small numbers in each group, the range in each group in this study. You can see that similar to mavacamten, aficamten was associated with a reduction in LV mass index, a reduction in maximal wall thickness, reduction in LA volume index, and in this case, a non statistically significant decrement in ejection fraction. But if we had larger numbers, you would see falls with aficamten as it does with mavacamten. So with that, I want to turn to the HCMR study and spend some time talking about this. This is a UO1, which means that it's a cooperative agreement with the NHLBI, which meant that there are several members of the NHLBI, including statisticians that sat on our executive committee, frequent conference calls. We were funded way back in 2013. It was really a massive effort and took years. The findings, the paper that came out on this Monday was slowed by a number of issues. One was COVID. Not all the European sites moved on to COVID research for 2 years and weren't doing follow-up. We ran out of NHLBI funds because of COVID, as well as a lower rate of events than we had anticipated. So we had to come up with alternative funding sources to complete the study. And then our CRO, we had to let them go and hire a new CRO, which meant contracting again for a second time with 44 sites involved. So a lot of effort, a lot of blood, sweat, and tears, but we got to the end. The goals of HCMR were to change the existing paradigm in HCM by improving risk stratification to be able to establish risk predictors to select patients for clinical trials, identify surrogate endpoints, and aim to reduce morbidity and mortality. We plan to recruit 2,750 patients with a minimum age of 18, a maximum age of 65. We didn't want competing risk factors for death in more elderly patients. This was not a screening study. We recruited patients with established HCM diagnosis from 44 sites in North America and Europe with dedicated HCM centers and strong CMR capabilities. We planned initially a 5-year study period. Obviously, it took longer than that. And our plan was to develop a score from the predictive model that can be used to assess risk given a patient's combination of risk factors. These are the primary and secondary endpoints of the study. The primary composite endpoint include cardiac death, both sudden cardiac death and heart failure death, as well as stroke death, aborted sudden cardiac death, including ICD discharge. Oops, sorry. Including ICD discharge, need for heart transplantation or LVAD. Our secondary endpoints include all-cause mortality, ventricular tachyarrhythmias, heart failure hospitalization, AFib, and stroke, non-fatal stroke, because fatal stroke is in the primary endpoint. This is our initial publication way back in 2015, the study design publication in the American Journal of Cardiology. The CMR protocol was fairly straightforward. It took under an hour. There was a localization, followed by native T1 mapping, followed by cine imaging. Then we gave in short and long axis, gave gadolinium, and did 3 time points of post T1 mapping, and then towards the end, late gadolinium enhancement. The genetics is led by Hugh Watkins at Oxford. The core lab involved next generation sequencing. It was not a discovery study. It was looking for known sarcomeric HCM genes and ruling out clinically related disorder genes. A number of serum biomarkers were measured by Carolyn Ho at the Brigham, who ran our core biomarker lab. But most importantly, the markers of hemodynamic stress and myocardial injury, NT-proBNP, and high sensitivity troponin I. This is the executive committee of HCMR. Stefan Neubauer and I, co-principal investigators. Bill Weintraub at the MedStar Research Institute in Washington, D.C., ran our data coordinating center and our CRO in the end. Hugh Watkins and Carolyn Ho I've mentioned, and then a number of CMR collaborators and investigators. These were our sites. We didn't have any in Switzerland. I had 11 in the UK, 2 in the Netherlands, 3 in Germany, and 4 in Italy. In the US, in North America, we had 22 sites with a predilection the Northeast. We had planned a 2-year enrollment period. It took us 3 years, a little longer than we'd hoped, but in the end, we ended up with 2,755. So we overshot a little bit, but which was good because it turned out that 5 patients had non-HCM related genotypes. So they were pulled out of the study, those 5 patients. So we ended up with the number we had planned for, which was 2,750. I don't mean for you to read this slide. It's too busy. This is from our baseline paper in JACC, just describing the patient population. I'll read it to you. The important findings: 49. The mean age was 49. 71% male. 16% underrepresented minorities. They were overweight. 41% either had a first or second degree relative with HCM, and hypertension was quite prevalent, about 37%. 92% of the patients were either in class 1 or class 2 NYHA heart failure. In terms of late gadolinium enhancement, as I mentioned earlier, 50% of patients had any LGE. Associations with the presence of LGE included the following. Interestingly, lower BMI, consistent with more of the primarily sarcomeric genetic disease, not the acquired disease. Family history of HCM, again. Maximal wall thickness, so thicker walls, more LGE. The few patients with an EF less than 55% had more LGE. Patients with a baseline arrhythmia, so history of AFib or a non-sustained BT at baseline had more LGE. And again, patients with a sarcomere mutation. When we looked at the relationship between morphology of HCM and LGE, the following interesting findings were noted. Patients with isolated basal septal hypertrophy, 2/3 of the patients had no LGE. If they had any LGE, it was generally very little, less than 5%. Contrast that to the patients with reverse septal curvature morphology, such as this patient. Remember, these 2 groups make up about 85% of the overall population. These were the patients with extensive LGE. And these are also the patients who more commonly have the reverse septal curvature patients, most commonly are sarcomere mutation positive. Yeah, there was an interesting relationship between biomarkers and LGE. There was a stepwise increase in NT-proBNP with increasing categories of LGE. And similarly, as split by gender, the high sensitivity troponin uh, T was increased with increasing levels of troponin. This is our summary image from a picture from the or figure from our initial baseline publication in JACC. We had identified two broad, relatively distinct populations, 40% or so who are sarcomere mutation positive, more commonly reverse septal curvature morphology. They were the patients with more late gadolinium enhancement, as it turned out, more interstitial fibrosis as well. But because their hypertrophy is in the mid-septum, less uh, uh, or either no or less LVOT obstruction, as compared to the large other group, 45% or so of patients, isolated basal septal morphology, sarcomere mutation negative, the more environment on the top of the polygenic background. And these patients had little to no LG or interstitial fibrosis, but because of the location of their hypertrophy, these are the patients with more LVOT obstruction. As part of the baseline analysis, we did strain analysis. This was published back in 2023 in JACC Imaging. This was led by Raymond Kwong, who led one of our CMR core labs at the Brigham, along with James White at Calgary. And they performed feature tracking strain on the cine images, measuring strain in every direction. And our findings were that the abnormalities in strain corresponded to the morphology of the underlying HCM, that in orange are the more abnormal strain. The patients with mid-cavity obstruction with the apical aneurysm had the most abnormal strain. The patients with isolated basal septal hypertrophy had the least abnormal strain, with the other groups in the middle. At the same time, we were working on ways of doing non-contrast scar imaging. This was pioneered by Stefan Piechnik and colleagues at Oxford in the UK under Stefan Neubauer's leadership. They developed a technique called virtual native enhancement. What that did was using an AI approach to overlay T1 mapping on cine images in the same slice, and using AI, develop a virtual native enhanced image, which one could argue is superior to the conventional late gadolinium enhanced image, at least in this individual patient. But there was excellent agreement in this patient, and in patients in general. You can see the virtual native enhanced images on the left and actual LGE images on the right, and the agreement is excellent. This group has also validated the same approach in ischemic cardiomyopathy, so we can look down the road to an AI approach to not having to give gadolinium to do scar imaging with virtual native enhancement. So that leads me to the latest data, which was, as I mentioned, just published literally 48 hours ago. So of the 2,750 patients, we had 98% who completed follow-up. So almost 2,700 patients completed follow-up with a mean follow-up duration of nearly 7 years. You can see our primary outcomes top, that we had 57 HCM-related cardiac deaths, 6 stroke deaths, 43 arrhythmic events, 10 heart transplants, and 1 LVAD placement. The arrhythmic events are sudden cardiac arrest, prolonged VT requiring shock, or appropriate ICD therapies. So there were 117 events in 104 patients, and we had powered our study to 100 events or 100 patients. In terms of sudden cardiac death or ventricular arrhythmia outcomes, there were 77 events in 69 patients. There were 34 sudden cardiac deaths. There were 18 resuscitated sudden cardiac deaths, and 20 appropriate ICD therapies for VTVF, and 5 sustained VT required cardioversion. And here's the bottom line. This is the primary composite outcome. which remember includes both arrhythmic and heart failure events. These are the five. In the statistical approach was an elastic net approach, which puts all really more than 40 variables in a pot, and after a lot of work, outcome the most likely independent predictors of the outcomes, and these were the five that came to the fore. Firstly, late gadolinium enhancement with a hazard ratio of 1.86 per 10% increase of LGE. Turned out the best single cutoff, again, it's a continuous variable, but 9% turned out to be the best cutoff, which is at the 95th percentile of the patient group. LV mass index with a hazard ratio of 1.09 per 10 grams per kilogram. Increase in per meter squared, increase in LV mass index. LVN systolic volume index, hazard ratio of 1.28 per increase of 10 milliliters per kilogram per meter squared. Because the way the NT-proBNP was distributed, it turned out the log of this value, because it's not normal distribution, was a potent predictor with a hazard ratio of 1.41 per increase of 1 unit in the log of NT-proBNP. And then the historical feature of a history of heart failure, either heart failure hospitalization or requiring an increase of diuretics, had a very potent increase in the hazard ratio, and likely predicted mainly the heart failure events, because this fell out of the predictive model for ventricular arrhythmic events. These are two graphs from our paper that's online at JAMA. And on the left is the LGE graph. You can see green is percentage of 9, which is the 95th percentile. Yellow is 20%, and that's the 99th percentile. So you can see that the event rate really jumps up when you go from 9 to 20% of LV mass. But 9 has a significant increase over the 75th percentile, which was 2%. This is the graph of presence, or the binary graph for history of heart failure or no history of heart failure. In terms of predicting the primary outcome, you can see history of heart failure is an important predictor. Turning to the model for sudden cardiac death and ventricular arrhythmic events, the four risk factors that fell out included, again, LGE percentage, left ventricular mass index, now LV ejection fraction rather than LVN systolic volume index. The higher the EF was protective, with a hazard ratio of 0.68 per 10% increase in ejection fraction. And then again, log NT-proBNP with a hazard ratio of 1.39 for these events. And the C index here was 0.76. I forgot to mention the C index for the primary composite outcome was very strong at 0.77. So putting these together is a very strong predictive in this population. We are developing a risk calculator based on these risk factors that are in the model, and are planning to apply it prospectively to retrospectively to a cohort of patients that have already been studied and have all of this similar data in the database. So watch this space for that publication. These are a graph of the arrhythmic endpoints, LG on the left, NT-proBNP log on the right. Very similar findings in terms of the green graph and the yellow lines in terms of prediction of the arrhythmic event for LGE. You can see the stepwise increase in event rate as you go from a log NT-proBNP of 5.6, which corresponds to about NT-proBNP of around 100, and then once you get into 1,000 or more, a lot of 8.4, you can see that the event rate is significantly increased. So in conclusion, HCMR has identified important imaging and biomarker risk markers in HCM for both sudden cardiac death and heart failure that will improve prognostication, and we hope that these will impact future guidelines in terms of management of HCM. And with that, I'll end, and I'm happy to answer any questions that you may have.
Thank you, Chris. It was a brilliant presentation. It showed all the overview and all this. We had actually a perfect timing for your publication and your presentation at our grand round. So
I could not have planned it better. It was fortuitous that we did when we scheduled this. I had no idea that the paper would be published 48 hours before.
Yeah, that's really great. So yeah, we've been very lucky. And congratulations also to this brilliant presentation and also publication in JAMA. I just read it yesterday evening, and I was really impressed what you all have done. I mean, so many centers, so many patients. So that's great. That's great evidence we now have. And also Hatem is here, so we are very happy to have
finally
him.
I made it finally. Sorry for being late, but
no worries.
After all these years, still online meeting issues.
So yeah, so let's maybe start with the question that were provided in the chat.
Yeah.
So the first one is from Dimpi Sheena. She asks, so for LGE quantification, we should not use interstitial fibrosis and only replacement fibrosis should be included. So what's the role of fibrosis on T1 mapping?
Yeah, so it turned out that T1 mapping, neither T1 nor ECV were included in the final model. And mostly in HCM, it overlaps with LGE, and so it's not independently predictive. Now, we only had T1 mapping in about 76% of the patients because 24% of the centers or the scanners didn't have the appropriate software at the time we did the study. But that being said, there was no added information from T1 mapping in HCM that you didn't get from LGE. So LGE is really the important finding in this disease. There are other diseases like amyloid where actually mapping is probably more important than LGE. So, but in HCM, LGE is more important than T1 mapping.
And maybe a quick question from my side. Do you quantify LGE in all your patients in your daily clinical work and how is your experience with variances?
Yeah, so certainly all our HCM patients, also all our sarcoidosis patients. And, we have to work carefully with the fellows. I'll point out that I'm the senior author of a position paper from the SCMR on how to do proper quantitation of LG and HCM, specifically in HCM. There have been some delays in getting that paper back to JCMR, but it should be going back to them soon. We hope to see that publication, but it's before the end of 2026. So there will be guidelines, and mostly what I mentioned, starting with a visual, but starting with a 6 standard deviation approach, but using visual analysis to fine tune that, because sometimes there is no normal area in patients with HCM that have a lot of interstitial fibrosis. So the 6 standard deviations can be tricky in HCM.
Yeah, that's something we encounter as well, that it might be. So we always use 6 standard deviations, and we put this also in the report that the method we used, which is recommended. I think the paper will be very helpful, the JCMR. So we're very much looking forward to seeing this one. Let's go to the next question. It's from the same person. So when hypertension and HCM coexist, yeah, that's daily problem. How do we decide ventricular remodeling is attributed to HCM or arterial hypertension?
Yeah, so you still use, again, in our study, 37% of patients had coexistent hypertension. So you use the definition that I described for defining HCM, and many of those patients have hypertension. Hypertension is a risk factor for HCM in patients with the right polygenic background. So you're looking for a wall thickness more than 15 millimeters, typically asymmetric in HCM, not always, but typically more than 15 millimeters, or with the exceptions that I mentioned. And they using the HCM calculator .org will help as well.
Okay, good. And maybe one question again from my side. Yeah, we have this cutoff value of 15 millimeters. However, when it comes to apical HCM, this is mostly not useful. So how do you
Yeah,
deal with
we
HCM?
go by morphology. If it's the classic morphology of apical HCM, it doesn't matter if the wall thickness is 12 or 13. It's called HCM. So the apex is thinner than the rest of the heart, so a lower threshold is used for the apex. Absolutely.
So already no tapering would also be already a hint for HCM, right? If you see no taper down to the apex. Okay, good. So we have a next question from Bernd Wintersberger from Toronto. So certain publications highlighted that insertion point fibrosis is not predictive of future events. So the amount of LGE in this area should be excluded from overall LGE mass.
Yeah, so that's not the case for HCM. That should be included. Insertion point fibrosis may not be predictive in other diseases, athletes or pulmonary hypertension, but in HCM, insertion point fibrosis is part and parcel of this disease. And so it absolutely needs to be included in LGE quantification, and it's part of the overall LGE mass in HCM.
Thank you. That's good. And that's the next question. In clinical practice, how do you deal with LGE that is out of low signal intensity, so below 6 standard deviations? So you completely
should be excluded. Yeah, it's interstitial fibrosis by definition and not replacement fibrosis. So the 6 standard deviation measure has been well validated against myectomy specimens by the Toronto group. That there's a paper in JACC Imaging from over a decade ago where they looked at myectomy specimens compared to the imaging and showed that the 6 standard deviation areas correlated well with areas of replacement fibrosis on histology.
So we should not report on this amount. And I think we saw that we have this 15% always as the risk gets up. But your data and the other data actually shows that from 9 or 10% already. So you think that the guidelines might change or will be adapted to this?
I think that the definition of extensive LGE, that cutoff value will likely decline based on, this is the first really prospective study. The prior studies are primarily retrospective.
Oh yeah. Okay. So good to know. So we will watch for this. Okay. Let's see if there's another.
There was a question, it's an important question about what about patients on CMIs? Because as I talked about, LV mass regresses. So as a percentage, LG might increase paradoxically, right? If it doesn't affect fibrosis as a percentage. Now, all the patients in HCMR are patients before the CMI era, right? They were recruited in 2014 to 2017. So I think we don't have enough data yet. There is some data that'll soon be under review that suggests that CMIs don't affect either absolute or percentage LGE over several years based on the data from the long-term extension of the Explorer trial. But what I encourage you, and based on HCMR, is that you get the HCMR at the first visit of your HCM patient. should be part of the initial evaluation. So before they end up on a CMI, you're going to have the data about their LV mass, their EF, their LGE before they end up on a CMI. That's what I would encourage, because
Okay.
you can't use data post CMI and apply it based on any HCMR based calculator, because it won't. We'll have to do a disclaimer that the HMR data is in the pre-CMI era.
Yeah, it's quite impressive how EKG changes under myosin inhibitors and troponin and BMP normalizes just after treatment. This is quite impressive. So yeah, there we will have a lot of things we need to learn in the future. So there's another one. It's how do you quantify? You said in sarcoidosis, and what is the cutoff for sarcoidosis when it gets nasty?
So in the U.S. Electrophysiology guidelines, the cutoff is around 5% of LV mass, LG as a percentage of LV mass as an indication for an ICD. It's like
What was it?
4.7% or something like that.
Oh, wow. Okay.
Yeah,
So
very,
around
very precise, but I think there are more studies coming, but that's generally around 5% of LV mass.
And there was one, how virtual LGE can address susceptible to contrast timing issues and fade out, and any integration of VN in with strain maps.
Yeah, we haven't done. That's an interesting question. Haven't looked at it. VNA versus strain. Certainly, the VNE. I'd have to look back at the paper which time. So we had three post-contrast T1 time points. I can't recall which one was used by the Oxford group. I'd have to look back at the paper for that. But certainly, it could make a difference as to when you make that measurement. And that does, the VNE, if you do again, the VNE, I'm sorry, VNE is pre-contrast T1. Let me back up. Forget what I just said. VNE is pre-contrast T1, so that takes away any issue of timing of post-contrast LGE and washout. So, but the correlation between the LGE and the VNE was good. So VNE is pre-contrast T1 plus synase.
Okay. Yeah. Okay, that's good. And maybe one last question from Tomas Podlesnika from Slovenia. Was left ventricular mass index a better risk factor than maximum LV thickness?
Yes, it was, and we discussed that at length in the discussion section of the paper. So, wall thickness is a 1D measure. LV mass index is a 3D measure of a better measure of the extent of hypertrophy in HCM, and it also takes into account cavity size. So it's a multifactorial measure as opposed to just the simple unidimensional wall thickness. So LV mass index is much more powerful than a simple wall thickness. Now, wall thickness is important for making the diagnosis in the first place, but for assessing prognosis, LV mass index is more important. We used wall thickness it was one of the variables that went into the statistical analysis, and it fell out because LV mass index is more powerful.
Okay, and just one addition was there. How to include or exclude right ventricular trabecular in the measurements of LV thickness? I mean, that's something we encounter every day, this question.
Yeah, so that's why CMR is a better technique for measuring wall thickness, because there's a paper in Circ Imaging from a few years ago showing that the agreement between CMR and echo is not all that good, because there's underestimation and overestimation by echo. Overestimation because the RV trabeculation is included in the measure, and we see that all the time in our CMR lab when a patient's sent to rule out HCM based on a echo over measurement, including the RV trabeculation. But it can be wrong in the other direction, because there are areas that echo doesn't image as well, like in the infraseptum, where is often in patients with reverse septal curvature, that's the thickest portion, and it's under measured by echo. So CMR is a better measure to get wall thickness accurately.
Okay, thank you. I think that's all of the questions. Do you have something, Hatem, to add, or
No,
any?
I'm just deeply impressed by this fantastic lecture, by this perfect timing with this tremendous publication. Congratulations also from my side.
Thank you.
Thanks to everybody also for this very vivid discussion. I think we are perfect in time.